Hello everybody, good morning, good afternoon or good evening, depending on where you are.
Great, thanks very much. So we now have the pleasure of listening to Dr. Attie-Bitach, who is a neuropathologist and expert researcher on disorders of the corpus callosum, amongst other things. And she's at the Necker Hospital for Children in Paris. All yours.
Can you see my screen?
Yes. Yeah, we can see it just fine.
Okay, so the part 2 of this session on genetics is now that we know the genetic causes, how it can be introduced into clinic. And what I'm going to talk about here is how we have now implemented exome sequencing in prenatal setting. So I'm not going back to what you already heard about what is exome sequencing. Basically, it's the test that is that allows to screen. I have a little. So it's a test that allows to screen all the coding part of the genes. You hear me well? Because I have a big echo. Okay?
We can hear you
She
well.
would need to turn her volume down on her
Okay.
laptop.
So I'll go on. You tell me if there's a problem. So
She's hearing herself in her own computer.
during pregnancy, almost 3% of them will show a fetal structural anomaly. It can be a major one, a minor one, but usually they are referred to a fetal medicine center where the role of this multidisciplinary team will be to evaluate the impact, the prognosis, and this depends on the time, on the number, on the severity of the malformation that was observed on ultrasound. But also one of the questions is there a risk of neurodevelopmental disorder? That means a cognitive impairment. And many tests will be done, including genetic tests, I will talk about today. And this can help to define the best management of pregnancy. So very often, hopefully, the couple will be reassured concerning the outcome of this pregnancy and baby. In very few cases that they can have, the obstetrician can install a treatment. It can also help to better manage the neonatal care, and in some cases, couple will orient and ask for a termination of pregnancy. In all cases, these are difficult steps for the couple, and they need psychological support. So let's go on the test that can be done. So at the beginning of the genetics, we could only offer karyotype, that means chromosomal abnormalities, but this has been evolved very, very, very quickly, and we have many tests that can be done today that allows to have other diagnoses. So first, that chromosomal microarray analysis was introduced maybe 10 years ago, 15 or 10 years ago, depending on the countries, and it brings information, additional information in 6% of cases. More and more exome sequencing have been performed in patients and So this is quite, these numbers are quite the same postnatally, and we will see together what are these diagnostic yields prenatally. So in 35% of cases, exome sequencing allows to have a diagnosis in the children with either one or several malformations. So as Christelle already told you in her talk, exome sequencing is the sequencing of the genes, that means the one who, the recipe. But we know that now that we also can explore the patient with the whole genome sequencing, that means also the region of the genome that are between the genes, and this brings further information in almost 10% of cases. So despite all the genetic tools that we have, 1/3 of the children with a congenital malformation, one or multiple congenital malformation, remain without a diagnosis. What about this test during pregnancy, done in fetuses? Several studies has shown that this test is feasible prenatally. That means we can offer this test in a turnaround time that of the pregnancy. And the diagnostic lead is variable in these different studies. But one thing is they are all agree to say that the diagnostic yield is greater when you have more than one malformation, and even that the diagnostic lead increases with the number of malformation. In brain malformation, the diagnostic lead is about 20%. So what about corpus callosum anomaly diagnosed antenatally? More and more, thanks to the ultrasound that are performed systematically now in all countries, a corpus callosum anomaly is diagnosed prenatally. So this is the most frequent brain anomaly, and it is often associated with other malformation inside the brain or outside the brain. And sometimes this corpus callosum anomaly remains isolated. Even in when the corpus callosum agenesis is apparently isolated without any other malformation in the brain or outside the brain, the neurodevelopmental outcome is still uncertain, because we know now that when it is apparently isolated prenatally, 15% of the patients, the newborns, have other signs after birth. So the neurodevelopmental outcome is uncertain. And of course, if we have the genetic cause, this will allow us to give an accurate genetic counseling. That's why we have now introduced the exome prenatal sequencing when we have a couple with a fetus with a corpus callosum anomaly, especially because we also know the genes, some genes at least, that can be associated with an intellectual deficiency, even if the corpus callosum agenesis was apparently isolated on imaging, on brain imaging. So our colleague from the Pitié-Salpêtrière Hospital showed that the most frequent cause of patients that have corpus callosum agenesis with intellectual deficiency, with a corpus callosum agenesis that was apparently isolated prenatally, is the coffin series syndrome, and the major gene is ARID1B. That's why now, when a corpus callosum is identified in a fetus, we will have several steps in the follow-up of the pregnancy. We will start with a microarray chromosome analysis that can find a chromosomal anomaly in, let's say, about 25%, 28 to 25% of cases. If this first analysis is normal, the pregnancy in France will follow up, and we will try to make a brain MRI at 30 weeks. But in between, we will offer to make a whole exome sequencing in accordance with discussion with our multidisciplinary team, including obstetrician, radiologist, neonatologist, pediatrician, geneticist, and fetal pathologist. At any one of these steps, if the prognosis is estimated to be poor, couple may choose to have a termination of pregnancy. If whole exome sequencing give a positive result, that means we have a certain diagnosis, this diagnosis can allow us to explain to the couple what is the prognosis of this disease. It might be good, poor prognosis, or still a certain uncertainty can remain. If we have no diagnosis by whole exome sequencing, this is quite good news, because that means that we don't have any, we don't add to the severity, we don't have any bad news to give to the couple. And usually now this leads the couple to follow up with the pregnancy, and the baby will be followed up at after birth. I will now go through the difficulty that we have in prenatal settings. First, as you can see on this slide, the diagnostic yields are usually lower in blue when we do the test prenatally, as compared to the test done in fetuses following termination of pregnancy in red, or children. Why this diagnostic yield is lower in the prenatal settings? We have several reasons for that. The principal reason is that when we analyze exome sequencing, when we interpret the data, this is based on the clinical signs that can be observed on imaging. But not everything can be observed on imaging. Many traits cannot be assessed during the fetal period, or because they are not accessible to ultrasound. For example, we don't know if the baby will have deafness or epilepsy. These signs are not observable on imaging. But also some signs of syndromes can appear later. So they are just absent at this period of life. So we have some difficulties in interpreting some genetic variants because we have partial phenotypes, and we don't know if this variant that we are looking at is pathogenic or benign. There are also other reasons why the diagnostic yield prenatally is lower. We have to give rapid results in the time frame of the pregnancy. That means that we don't have really time to maybe go further on a variant that maybe we think it could be pathogenic. So it remains like a variant of unknown significance. And there is a rule in prenatal is not to give back the results of variant of unknown significance. That means when you don't know if this variant is pathogenic, we don't talk about it. Two other reasons are that we don't, sometimes we have a variant in a gene, but we don't know if this can explain the signs that are observed prenatally, because for most of the genetic disorders have been described in patients, children and adults, and without describing the prenatal history of the pregnancy. So we don't know correctly, we still don't know enough the prenatal signs of most genetic disorders. And finally, there is a clinical variability of genetic disorders. That means some patients can have a mild form, and we know that others can have a very severe form, what we call in our language, extreme phenotypes. And sometimes we cannot correlate that. That means we cannot say that this variant can give such severe phenotype, but just because we still don't know it. So this is the pathway for performing prenatal and high throughput sequencing. So exome sequencing in most cases, but sometimes some center offer prenatal genome sequencing. There is a pre-test counseling that is mandatory, that will be followed by a post-test counseling. This is an important step because we have to know the wishes of the couple. The familial history is important for geneticists, and we have to give information on the test, its limitation, and all the possible results. As in, some examples are here. We have to inform the couple that, for example, variant of unknown significance will not be returned during the prenatal period. Incidental findings in our center are not returned prenatally. That means what we call incidental findings are genetic anomaly that can give a disease or a predisposed to a disease that has nothing to do with why we did the test. So sometimes we find a variant that can, for example, predispose the couple, the woman, the lady, to a breast cancer, but this will not be returned prenatally because it's not the right moment to do that. So all these informations have to be explained to the parents, and it also explained why we have to see the couple after birth, after the birth of the baby, because we will be able then to go further on this variant of non-significance, or maybe give back to the couple these incidental findings. Finally, we have to explain to the couple that a negative result reduces a risk of a severe disorder, but does not exclude a genetic cause. The reason for that is that whole exome sequencing does not assess the whole genome. Some regions of the exome are not correctly sequenced for technical reasons, and some genetic disorder or epigenetic anomaly are not seen when we do this technique of sequencing. So for all this reason, it's not because you have a negative whole exome sequencing that a genetic cause is completely excluded. Let me go through some examples. In this monochorionic diamniotic pregnancy, so twins, both female fetuses had a corpus callosum at genesis. This was apparently isolated at 24 weeks of gestation. We performed the brain MRI of the parents, and both were normal. We did a microarray chromosomal analysis that was normal, and we did then a whole exome sequencing, and we found a de novo mutation in a gene called CDH2, and this gene was just reported a few months before as a gene responsible for a corpus callosum agenesis associated to neurodevelopmental defects, and sometimes, not in all patients, some other malformation. So the couple decided, because of this association to other anomalies and constantly neurodevelopmental disorder, to go to the termination of pregnancy. In this example second example, in the first pregnancy of an unrelated couple, at the second trimester ultrasound, a short corpus callosum was observed, and it was also described as short and thick. Several ultrasounds were made, and the corpus callosum was always very small behind the first centile. The chromosome analysis was normal, and the parents' brain MRI was also normal. So we counseled this couple who asked for a whole exome sequencing, and this pointed to a de novo mutation of DCC. So Christelle Despienne also told you about this gene, which is responsible for mirror movement with possibly corpus callosum anomaly, but never with any neurodevelopmental disorder, so no intellectual deficiency. Not only we can reassure this couple because this is a good prognosis gene, but also we know that this is de novo. That means that the parents are not carrier of the mutation, and they have a very low risk that it can happen in the next pregnancy, very low risk of recurrence. The third example concerns a family where a first pregnancy was terminated at 30 weeks of gestation because of a corpus callosum dysgenesis. At that time, for this first pregnancy, just a chromosomal microarray analysis was performed. So we had this fetus to examine. We confirmed that the corpus callosum was short and thick. We did at that time what we call panel sequencing. That means sequencing of the genes that were known at that moment to be responsible for a corpus callosum anomaly, and this was normal. So at the next pregnancy, it was followed up very carefully by our fetal medicine center. And again, in these fetuses, they saw a short corpus callosum that seems complete. This time, some tractography was also performed by the radiologist. We did the parental MRI, both were normal. And we went to a whole exome sequencing this time with the two fetuses and both parents, and we found no diagnosis. This was a very hard decision for this couple because they first interrupted a pregnancy. So psychologically, it was like they was giving a chance to this baby, but they didn't give it to the first. But finally, with a lot of support, psychological support, they decided to go on with this pregnancy, and the baby is born and we have good news. We are waiting to see him at 6 months of life. And the last example is the termination of pregnancy at 37 weeks of gestation for a complete corpus callosum agenesis, and because at the third trimester also appeared oligoamnios, that means a lack of amniotic fluid. That is sometimes can reflect a genetic disorder, an underlying genetic disorder. So we also had this baby to examine in fetal pathology, and we found that this baby had some facial dysmorphism. You can see these plastic ears that are asymmetric, but we also found that the size and the weight of the brain were above the normal, so what we call megalencephaly, and he had frontal bossing. In this baby, we did a whole exome sequencing, and we found a mutation in a gene called ZBTB20. So this is a gene that is known to give intellectual disability syndrome with myopathy, associated to myopathy. It is a transcriptional repressor, and there is a mouse model, and this mouse model also has a partial corpus callosum agenesis, further confirming that the brain phenotype here was due to this ZBTB20 mutation. It's a de novo mutation, so the parents has no risk of recurrence for the next pregnancy, or a very, very low risk. And as you can see here, usually the syndrome is associated to a macrocephaly, that means a high head circumference. Here, the head circumference was normal, but it was the brain that was above the norm. So just to say a few words on fetal pathology, it's very important and crucial because it gives additional information as compared to the prenatal imaging. And my last slide on this fetal pathology, just to explain why it is important to examine these fetuses when there is termination of pregnancy. It's basically a clinical examination of the babies. So look at them like a pediatrician would look at a baby, to make X-rays. And we also, during the autopsy, can take some samples of all the organs to have the histology and have the phenotype at the cellular level. So this is a specific protocol. It is very important because sometimes we have retrospective diagnosis, and it's important to go back to this fetal examination. It also gives access to tissue in case we have a variant of unknown significance and we want to go further to have some functional analysis. And also having diagnosis in fetuses with such well-characterized phenotypes give us a better knowledge of prenatal signs of the genetic disorder that we need. Also, just to tell you that the French Society of Fetal Pathology has made a film, video, a short video of 7 minutes, just to explain to the couple what are the steps of the fetal pathology examination. So you can find it on this link. So in conclusion, when the prenatal exome sequencing can be done prenatally, is useful and can orient the couples in their decision. In this study done for our colleague from the Pitié-Salpêtrière and Trousseau hospitals in Paris, they did prenatal exome sequencing in 65 fetuses with abnormality of the corpus callosum. And what you can see here is that the corpus callosum was either apparently isolated in 83% of cases, or associated to other signs. You can both see the diagnostic rate because they identified a cause in the associated cases in 42% of the fetuses, while they found a genetic cause in only 15% of the isolated cases. So a genetic cause is more often found when the corpus callosum anomaly is associated to other anomalies, on structural anomaly on the imaging. What you can also see is the outcome of these pregnancies. And when you have a genetic cause identified, most of the couple opt for a termination of pregnancy. And when you have no diagnosis found on whole exome sequencing, 90% of the couple opt for continuing the pregnancy. So it's reassuring. So in conclusion, fetal exome sequencing improves the prenatal management, help to the decision-making of the couple, allowing us to make an accurate genetic counseling. Sometimes it's help for the neonatal management. We still have a lot of challenges when we deal with genomic analysis prenatally because of the lack of some signs. The presentation are often not specific. We have partial phenotypes, sometimes more severe phenotypes that what, as compared to what is known, but still this deserve the introduction of fetal exome sequencing in clinical setting during fetal medicine, and in particular in corpus callosum agenesis. So thank you for your attention. This is all the team. We work with 2 prenatal centers in Paris. This is the team who performed the exome sequencing and all the geneticists and cytogeneticists. I also thank all of you. Most of you must be behind the screen, maybe all of you, I don't know. Because if we know the genes, it's thanks to the patients. So it's important to get involved in the research that allow us to find the genes, but it's also thanks to the researcher that hardly work on the genes that are discovered to understand that function and maybe one day understand how we can treat this disorder. So thank you.
Good afternoon, everyone. Good afternoon, everyone. That was a lovely presentation, and whereas Dr. Attie-Bitach's focus was mostly on prenatal, I'm going to talk about work that my group has been doing on understanding the genetics of dysgenesis of the corpus callosum, but in children and adults. Okay, so what is this? Okay, so our team has been recruiting, and I'm going to kind of run through some of this more quickly to catch up. Recruiting patients and families, and we're obtaining medical records, we're reviewing MRI scans, and then conducting whole exome sequencing, which you've heard a little bit about. And it basically allows us to look at all of the genes, all of the coding region in the genome. Where we think most of the biology will be more accessible. So right now we've yeah, it says it's all. Okay, is there an echo? So sorry, what's the solution for the echo? It's better now? Okay. Okay, so oh, there is an echo still. Is it still echoing? Yeah. How about now? Is that better? Sorry.
Okay, how about now? Is that better? Okay. All right. So again, for sake of timing, I won't really go through a lot of these details, but just to tell you that we had a large diversity of individuals who had both complete ACC as well as partial ACC, um, as well as dysgenetic in overall terms. And many of the other features that you've all been hearing about are well represented in our cohort of participants. And that's going to be helpful when we try to understand what's the connection between the genetics and the clinical outcomes that I'll talk about briefly. And this again is just like there's a broad diversity of imaging findings, there's also a broad diversity of clinical challenges. So you can see here that a third of the individuals had epilepsy. A little more than a third of them had low tone hypotonia. 50% of them had behavioral concerns. So there's a broad diversity of challenges and issues, as well as outside of the CNS, where, for example, here a third have orthopedic concerns. And then often we want to know what's the balance between males and females. And again, in our cohort, we had approximately 45% females, which is fairly typical because there's usually a slight increase in boys because of the representation on the X chromosome. And then again, what we then, as I said, we then took the DNA from all the families, and we looked at the whole exome, the part of the genome that contains the genes, and we found that approximately 57% of the individuals, when we did whole exome sequencing, had a diagnosis. And I think that that's slightly higher than what Dr. Attie-Bitach talked about, but it's in line with what we've seen in other studies. Most of these are autosomal dominant. You can see that 73% of them are that way, which means that they're a single genetic change usually in one individual and not in the mom and dad. And we had other findings as well. So earlier today, Dr. Richards asked a really great question, which was, how do we take the information that we get, the genetic information, and come up with a diagnosis? And what this data here is looking at is, what are the odds that you find a mutation just based on what the mutation rate is in the general population, just a random selection of, 1,000 people off the street. It's not quite done that way, but that's essentially the effect. And so we get what's called the expected rate, and then we can look in our cohort and see what the observed rate is. So for what we call protein truncating variants, meaning total loss of function of that particular gene, that we would expect 48 individuals to have one of those genetic changes. But in our cohort, we had 187. So what that tells us, it doesn't tell us that any specific gene is connected, but it tells us that if you look at individuals who have DCC, that there's an overrepresentation of these mutations in that population. And it suggests that this kind of mutation is the likely cause for many of those individuals. We looked at small missense mutations, so where one letter of DNA is changed. So if you remember, Dr. Depien referred to the 4 letters of DNA, A, C, T, and G. And so that would mean that literally one of those letters would change from an A to a C, or a C to a G. And in that situation, again, the expectation would be that we would see 220 individuals with those mutations, but we actually saw 326. So this overrepresentation tells us in a large group of individuals that that's what's behind the genetics. And then this is, we asked to collaborate with a clinical laboratory called GeneDx. Many of you may have had whole exome sequencing done with them. They're one of the larger groups, and they contributed approximately 600 families to our data set. And if you look at theirs, they got 380 when they were expecting 272, almost the same exact amount as ours, and 204 when they were expecting 59. So that's also very important because it suggests that there's not an ascertainment bias in either of these groups, or they have the exact same ascertainment bias. I guess that's still a possibility. But these are very large numbers and suggest that these kinds of genetic changes are important for understanding disorders of the corpus callosum. And again, so for sake of time, I'm going to go through this pretty quickly. This is the genes that we found that were most commonly affected in our cohort. So for example, ARID1B, which is a very common gene in ACC, we found 18 individuals that had protein truncating variants. So what we call loss of function, where one of the genes, one of the copies of the gene is not working. But interestingly, we found 0 missense mutations. So not only are we seeing large numbers, but we're seeing different kinds of mutations in different genes. So by comparison, tubulin, TUB-A1A, this one right here, has 0 protein truncating variants. So that form of genetic injury is not present in that gene, but the missense change where one letter is changed, that accounts for all of the genes, or rather all of the cases where TUB-A1A was altered. So we have a few of these genes where there's large numbers, but there are many others that have smaller numbers. So this is, in addition to both novel genes, as well as commonly mutated genes and low rate mutated genes, we have ones where we think that they might be causative, but we don't know yet. And so we're calling these candidate genes. So for example, right here, there is an actin binding protein called ABI1, and we found only 2 missense mutations in our cohort, but it had a peculiar finding where all 2 of those individuals had the exact same genetic change. So there's, 3 billion letters of DNA, and of those 3 billion letters, each of those 2 individuals had the exact same letter change. And so that tells us that that's a very likely cause of that, even though there's only 2 individuals. We then went on to reach out to other geneticists and found that that gene was mutated multiple times. And so that tells us that that's a new gene and something that we should focus on in terms of understanding the biology of callosal disorders. I'm just going to skip over that. Okay. And then what we did is we took all of this genetic information and we tried to overlay it with both the imaging findings as well as the clinical findings and look to see whether there was any correlation. And so this is just telling you that of the individuals, of the 500 or so individuals in our cohort, that about 250 of them had moderate to severe delays in their development. And that about 40%, about 175, had normal development or only mild impairment. And so the way we defined mild was kids that were in regular class but had therapies, whereas kids that had were in full-time therapy classes and had significant disabilities fell into the moderate or severe category. And then if you then take that information and superimpose that on their brain imaging findings, we see lots of interesting observations. And this is just, okay. And again, for sake of time, I'm just going to give you the highlights. So in individuals who had complete absence of the corpus callosum and nothing else, so they didn't have any other brain imaging findings, they didn't have any other findings outside of the CNS, those individuals had mild or mild developmental delay or normal development about 80% of the time, right? So that suggests that we don't know this for sure, but this suggests that if there's an MRI and the MRI shows that it's completely isolated and the doctor finds nothing else, that the child would have an 80% chance of having a mild challenge or no challenge at all. In converse, if they have again, I apologize, these little things get in the way. If you had a thin corpus callosum and you had other anatomic features either in the brain or outside of the brain, that you would have the inverse, that approximately 90% of those individuals had moderate to severe developmental delay, and a very small percentage, about 5%, had mild or no developmental impairment. So this is, obviously very important information for us to follow up on. This is just us doing it once. We want to see other groups do it again, and that's actually one of the benefits of the collaborative IRC5. Okay. And then, why is this not working? Okay, I'm just going to, okay, and this is the same concept, but looking at a much larger set of issues instead of just looking at whether it's ACC or a hypoplastic or thin corpus callosum. We looked at other features, and those also had, I think, findings that people have wondered about that I think may be meaningful. So, for example, if the MRI shows colpocephaly, which is dilation of the lateral ventricles in the back part of the head, those individuals are 3 times less likely to have developmental problems than the general group. So it means, I don't know, I wouldn't say that it means that it's a protective effect, but rather that it correlates with a better outcome. And that kind of analysis also holds up for individuals who have a normal or large anterior commissure, as we assessed it, as well as Probst bundles. So all 3 of those categories suggest that if you see those, that those are associated with a better outcome. We also did this same analysis looking at genetics. And again, this. So approximately 250 of our individuals in the study had a genetic diagnosis, and approximately 200 did not. So again, fitting with the 57% that I mentioned earlier. And again, if you're likely to have a genetic diagnosis, features that show that to be the case would be a hypoplastic corpus callosum. So those individuals are going to be 6 times more likely than the general population in having abnormalities. And then inversely, if the anterior commissure is normal or large, that those individuals would only have 4 out of 10 cases where there would be a diagnosis, whereas 10 out of 10 would be present in the general cohort. Okay, about 25% of the individuals in the cohort had epilepsy. And again, a full 3/4 of them did not have epilepsy, which I think is a very encouraging information. Sorry, having some technical difficulties here. Scott, any thoughts about? Nope. Okay, I'm just going to skip that for sake of summary. If the scientists are interested, we have random forest analysis, but then we can just skip that. Okay. So in summary, we've done investigations of about 500 families now. We've collaborated with GeneDx to add their 600 or so families. So this is the data is coming, at least for the genetics, is coming from approximately 1,100 families. And then the clinical data that I showed you came from just from our cohort, because they're not able to share that kind of information. We showed that there's strong correlations between imaging findings and clinical outcomes, as well as imaging findings and genetic diagnoses. And then again, combining all of this data together is what has allowed us to develop these initial hypotheses that we will then hopefully test with either another collaborative team or that we will recruit these individuals and do it as part of our efforts. And so one of the most striking features has been that individuals who have isolated ACC seem to have a fairly optimistic long-term outcome, and that's actually fitting with work that Dr. Attie-Bitach and Delphine Heron in France have presented. And then individuals who have a thin corpus callosum, but also have other brain imaging features are more likely to have significant impairments. So these are important, but only preliminary findings. And again, we look forward to trying to take this to the next step. Okay, thanks very much.